Maple HCM up now.
Thank you. So on behalf of my co-investigators, I'm pleased to report today here the results of the Maple HCM study. Here are my disclosures. So obstructive hypertrophic is characterized by a hypercontractile left ventricle hypertrophy and left ventricular outflow tract obstruction, resulting in limiting symptoms and reduced exercise capacity. Aficamten is a new cardiac myosin inhibitor that targets the underlying pathophysiology of hypertrophic cardiomyopathy by reducing myocardial hypercontractility. Aficamten has already demonstrated several benefits in patients with obstructive hypertrophic cardiomyopathy when added to standard of care medications. The most commonly used standard of care medication for patients with symptomatic obstructive hypertrophic cardiomyopathy is beta blockers. We have been using beta blockers as the first-line treatment for these patients for nearly 60 years, despite limited evidence. In fact, beta blockers are recommended by both European and American guidelines with a class 1 level of recommendation as the initial first-line therapy for these patients. In the Maple HCM study, we sought to evaluate the safety and efficacy of aficamten in monotherapy compared with metoprolol in monotherapy in these patients. The primary endpoint of the study was exercise capacity assessed through peak VO2 in CPET. Secondary endpoints included symptoms, Valsalva VO2 gradient, NT-proBNP, and certain echocardiographic parameters like left atrial volume index and left ventricle mass index. This slide shows the study design, and you can see here that we randomized 175 patients to receive either metoprolol plus placebo or aficamten plus placebo. We follow the patient during 24 weeks, and during the initial 6 weeks, we up-titrated both investigational products using echocardiographic parameters and vital signs. Both patients with recently diagnosed or treatment-naive obstructive hypertrophic cardiomyopathy or with chronic hypertrophic cardiomyopathy with standard of care medications could participate in the trial. If the patients were receiving already standard of care medications, they had to undergo a 2-week period of washout before undergoing screening procedures to qualify for the study. The patient's characteristics of the participants in the study were milder, showed a milder phenotype in comparison with previous participants in CMI studies. The medium NT-proBNP value was around 500. You can see here that the mean peak VO2 was around 20 mL per kilo per minute. And regarding gradients, resting and Valsalva gradients were around 45 to 50 and around 75 millimeters of mercury, respectively. Of note, we observed that there were more patients with hypertension in the aficamten group than in the metoprolol group. During the study, the majority of participants were exposed to the higher dosage of metoprolol and aficamten. At week 24, 10 patients in the metoprolol group did not tolerate the drug, in comparison with 1 patient in aficamten group. By week 24, in the metoprolol group, we observed a mean decrease of 6 beats per minute in their resting heart rate and a mean decrease of systolic blood pressure of 6 millimeters of mercury. In the aficamten group, we did not observe change in resting heart rate, and we observed a mean increase of 5 millimeters of mercury. And here are the results of the primary endpoint of the study. During 24 weeks, the metoprolol group, we observed a mean reduction of 1.2 mL per kilo per minute in peak VO2. While in patients on aficamten, we observed a mean increase of 1.1 mL per kilo per minute. The least square mean difference between the aficamten and metoprolol groups were 2.3 mL per kilo per minute. This was statistically significant with a p-value of less than 0.0001. And this is above the minimum considered relevant difference of 1 mL per kilo per minute that we use in clinical practice. We did not observe heterogeneity across all the pre-specified subgroups, including the time of diagnosis of hypertrophic cardiomyopathy. Furthermore, when analyzing the secondary endpoint, improvement in NYHA class, change in KCCQ, NT-proBNP levels, change in gradient of Valsalva, change in left atrial volume index were all statistically significant in favor of Aficamten, whereas left ventricular mass index was not statistically significant within groups. Regarding symptoms, at week 24, we observed that 51% of Aficamten-treated patients and 26% of those receiving metoprolol had an improvement of one or more classes in NYHA class. Of note, at week 24, 40% of patients on Aficamten were completely asymptomatic, NYHA class 1, while this happened only in 9% of patients on metoprolol. Regarding quality of life, assessed through the KCCQ, we observed improvements on the patients receiving metoprolol, but the improvement observed in patients receiving Aficamten was larger, as you can see here on the slide. Surprisingly, in this study regarding obstruction at rest and with Valsalva, we did not observe improvement in this study with metoprolol in both parameters. While in contrast, you can see here that we observe on those receiving Aficamten a profound and quick response with a mean level at the end of the study below the thresholds that we use in clinical practice for both parameters. Regarding NT-proBNP and left atrial volume index, which are two parameters related with diastolic dysfunction, they went up increase in patients receiving metoprolol, while they decrease in patients receiving Aficamten. Of note, the NT-proBNP levels at week 24, the mean value, were at the upper limit of normality in those receiving Aficamten. Regarding safety, a total of 3 patients had to stop metoprolol during the trial due to adverse event, in comparison with only 1 patient in the Aficamten group. There were a total of 26 patients who had to reduce the dose of metoprolol that they were taking in the study, compared to 4 patients on Aficamten. Consistent with the mode of action of Aficamten, we observed a mean reduction in left ventricular ejection fraction at week 24 of 5.3% in the Aficamten group compared to a reduction of 0.5% in the metoprolol group. But only 1 individual in the Aficamten group had an ejection fraction below 50% during the trial, and he was completely asymptomatic with no signs or symptoms of heart failure. Moreover, this got reduced without discontinuation of Aficamten. So in conclusions, in patients with obstructive hypertrophic cardiomyopathy, Aficamten monotherapy was superior to metoprolol monotherapy, with statistically significant and clinically meaningful improvements in exercise capacity, symptoms, Valsalva gradient, NT-proBNP, and left atrial volume index. Despite we have been using for more than 60 years beta blockers to treat this disease, and the strong evidence of on-target hemodynamic effects in heart rate and systolic blood pressure, there was no decrease in gradients with this drug, either at rest or with Valsalva. Aficamten was well tolerated. So overall, in our opinion, the results of the MAPLE-HCM study support Aficamten monotherapy as the newer first-line therapy of choice for patients with symptomatic obstructive hypertrophic cardiomyopathy. I want to thank everybody who has made this trial possible, and particularly participants and their families. And I want to conclude, I'm delighted to announce that the results of this study have been published today simultaneously at the New England Journal of Medicine. Thank you.